Good morning, everyone. Welcome, and thank you for joining the Women's Health Day of Learning and Luncheon. My name is Melissa Porty, and I am delighted to be a co-chair for today's luncheon. Your generous support of today's event is very greatly appreciated. Proceeds from this event will benefit all women's health initiatives at the Mount Sinai Health System. With 7 hospital campuses and more than 45 ambulatory practices citywide, there is a Mount Sinai physician within walking distance of all of us. The Mount Sinai Health System cared and continues to care for so many of the people in my life, and I am thrilled to be able to support their efforts to improve the care given to women. It is now my distinct honor and privilege to introduce Dr. Marie-Noelle Langan, who is the Associate Professor and Medical Director of Operations, Division of Cardiac Electrophysiology for the Icahn School of Mount Sinai. Please welcome Dr. Langan.
Good morning, everybody. So we have an hour to have fun. Well, that's the goal. The most important goal is to make everybody realize what a palpitation is and to recognize that there is a huge and very large, broad of reasons why people feel about palpitations and to tweak the degree to which one should worry about them and how one can approach them. And if there is one message, it is that we are in the modern era, and in the modern era, there's no reason to be worried about your palpitations because we can record them. That would be my message of the day, okay? So palpitations happen to be extremely, extremely common. So first of all, what is a palpitation? Because interestingly enough, I see patients every day, all day, and it is amazing what people think a palpitation is. Palpitation actually means that you feel your heart skipping or beating in an abnormal way. That is a subjective feeling of you. It is not something that I am defining. You are defining it. So when a person says, I have a palpitation, it means for some reason they're recognizing their heart is beating differently than they think it normally does. Now, very often, actually, it is doing exactly everything normal. So it is not necessarily truly a recognition there is an abnormal rhythm. That's a different statement than saying I have a palpitation. So a palpitation is up to you to recognize. What it is up to us to determine, all right? And unfortunately, because of that, there is a huge variety of options of what people are feeling. And so it is of great help often to recognize what those palpitations feel like to help define what we need to do about it. So there's palpitations that are fast heartbeat going regularly and strong, and there's palpitations that skip, and there's palpitations that go fast and irregular. And then there's just palpitations that you feel your heart is fluttering or doing something funny and you can't describe it. And interestingly, everybody describes different things. Sometimes it's very classic and we can really figure it out, and sometimes we can't from the history. But it is good to kind of think of it in those kind of parameters. Is it going fast? Is it going irregular? And is there any pattern? All of those things will help the doctor have a little sense of how to approach the problem. Now, a rhythm so the heart is basically divided into 4 chambers, as you know, and it has 2 separate pieces. And I tell my patients all the time that it's, to me, like a house. There is a contractor, we call that the general cardiologist, and he takes care, or she, mostly she's, take care of all the different aspects. And then there are specialists within cardiology who take care of the plumbing. Those are the people that do the angiograms, do the angioplasties, coronary disease you hear about all the time, or those that watch over the valves and make sure that the flow is going through the valves. And then there's the electricians. I'm an electrician. The electricians, we call them electrophysiologists, and basically we're responsible for understanding anything that is causing the rhythm to be abnormal. So the electricity of the heart is normally very organized. It turns out every cell in your heart can make electricity. And therefore, that's why we have such a range of what a palpitation can be. So every cell in your heart can make electricity. And the way it makes electricity is by opening and closing channels that allow ions to go through, magnesium, potassium. You've heard all of these things before, but basically it gates open and then that makes the muscle contract. So every muscle can make an electrical signal, But we have a group of cells that are the bosses, and those guys are supposed to keep everybody in line. But like, any good, exciting thing, you have to have a few rogue cells that do things every once in a while differently. So there are many, many reasons you can have palpitations. So one can be that any of those cells are firing separately, and the other can be that you're actually born with a short circuit. And then last of all, it can be because you have had some kind of damage to your heart. And so you can imagine all of those situations are completely different in terms of what you're going to feel, how you're going to respond to them, and what the risk is. And so therein lies the difficulty. So how do we approach the problem? Well, essentially, we actually divide arrhythmias into two main categories. We call them the supraventricular and the ventricular. So supra means above, and those are basically all of the rhythms that are generated in the upper chambers of the heart. And as you may know, the heart has four chambers, two on the top, the atria, two on the bottom, the ventricle, and really it's the ventricle that does the hard work of pumping the blood out. Okay, so what you really need, what you really want is your ventricle, the lower chambers, to contract efficiently to get blood flow out, and not too fast, although sometimes you want it fast, like you're running, you want it to go fast. So you want it to be appropriate to produce the blood flow that you need. And the symptoms you are going to get from an arrhythmia has to do with either the heart going too fast, the heart going too slow, or being discoordinated. Okay, turns out, in general, you do not need much coordination between the upper chambers and the lower chambers. You just need them to give the right flow and the right heartbeat. What you really need is your lower heart rate to go at a certain rhythm that is useful to pass the blood through. And even that does not need to be regular to produce the blood flow you need. It just needs to be approximately the right rate. So there's a lot of give in the system. That's the point of what I'm saying. Okay? Turns out the upper chamber rhythms, the supraventricular, are generally not dangerous. Okay? They, however, can be very, very symptomatic. They actually can be faster than some of the lower chambers. So why are they not dangerous? So that's the first lesson, is that heart rate is not really the only determinant of what is dangerous. It is kind of common knowledge that people get pacemakers. Interesting, pacemakers are used to make a slow heart rate speed up. There is no way to speed up your heart with medications consistently, and so therefore we have pacemakers. So if the heart is going too slow, we will add a pacemaker. Okay? It turns out, interestingly, because everybody knows about pacemakers as they're very common, that slow heart rates rarely are dangerous. They are important to know about, but they actually rarely cause you to die suddenly. Really what causes people to die are fast heart rates. But I just said the rate itself is not what causes the problem. So what is the problem? The problem is that your system, from the top to the bottom, is rigged to be very efficient at producing the at sending down the electricity through the lower chambers so that they contract in a very coordinated and very useful and efficient way. Okay, so we call that the conduction system. That conduction system is a very specialized set of cells. So when electricity comes from the top, like it's supposed to every single time, it congregates into this conduction system and sends the electricity in a very coordinated way to produce a good heart rate. If the electricity comes from the lower chamber by itself, one of those cells fire, that electrical activity is going to be much less organized, okay? And because it's much less organized, it produces far less blood flow. So even a rate that is slower coming from the lower chamber in this disfractionated way is going to be much, much less efficient than a fast heart rate going through the normal system. Okay, so that's why we can separate out the supraventricular, the ones that happen on the top, from the ones that happen on the low. So what we're always looking for first is to try to differentiate where is this electrical abnormality coming from. Okay, is it a top problem or is it a bottom problem? The second thing to know is the most important factor as to whether you are going to do well with a rhythm problem is not the rhythm, but what is your underlying heart structure, what's going on in the heart. And we could think about it fairly simply. Somebody that has a very tight artery that doesn't pass blood flow very well is not going to like having even a benign rhythm that's going 180 beats per minute compared to somebody whose heart flow is fine. So even though the rhythm itself is benign, it may actually cause a problem. So more often than not, what we're going to look at first, interestingly enough, is what's the structure behind this system. So whenever patients come to me, I say, surprisingly, no matter what I record, it's more important for me to know, do you have artery disease? Are your valves okay? And what does the muscle look like for me to be able to tell you whether I have to worry about it? All right? So based on what I just said, two things. One, we are going to try to classify the rhythms into upper chamber versus lower chamber. And even within that classification, we're going to want to know what is the structure of the heart. What do the valves look like? What does the muscle look like? What do the arteries look like? Okay? So based on those two pieces, that I want to talk a little bit about what kind of things are we looking for that are particular to women. Okay, since this is Women's Health Day, I'll talk a little about that. Now, interestingly, one of the things that is surprising and important to women is if you want to go find an electrophysiologist and you want to have a woman electrophysiology, good luck. We have 15 of them. I'm the only girl, which is why I'm director of operations. I tell everybody it's like chief mom, because that's what moms do. So we are actually few and far between, unfortunately. We are getting better, but that is an issue. Now, who cares? It doesn't really matter. Of course, it doesn't really matter, except, interestingly, there are quite a few things that are particular to women when it comes to rhythm that sometimes people forget. And I'll start talking about one that's really obvious, which is that women get pregnant. Now, interestingly, I just said that the rhythm, what the rhythm problem isn't sometimes not as important as what it is, in what environment is it happening. So, of course, if we think about it, a woman that's pregnant is a very different environment than one that isn't, because you have a second person you have to take care of who may not like the fast heart rate. And so for that reason, there is a couple of things to talk about pregnancy and rhythm problems. So one is it turns out that pregnancy may produce an increase let's take my glasses off here, an increase in any arrhythmias that you've had before. So women of childbearing age, if you're having palpitations, should have it checked out before they consider getting pregnant. Not because it's necessarily going to be deadly, but first of all, it's going to be very bothersome. And second of all, it may be deadly. Because the other thing that turns out is that there are very few deadly rhythm problems, and there are very few deadly rhythm problems in young people, but the one that is the most prominent, which is called the long QT syndrome, is actually exacerbated often during pregnancy. And so that is a major, major tragedy if we miss that. So message number 3, I think I'm at, is that if you are or if you have a daughter or anybody that is at childbearing age and they are having palpitations, that should be really investigated before they get pregnant to make sure that it is taken care of and addressed. The large majority of rhythm problems, if we can diagnose them, we can take very, 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 very good care of them, which is another extraordinarily important message, and which is why I said all rhythms should be recorded, because if we can fix them, we should fix them. So we can fix them in many, many ways. We can fix them by actually getting rid of a short circuit, or we can fix them by medications. We can fix them by putting in a defibrillator or a pacemaker. So we have all different ways that are actually fairly simple, quite low risk, and very successful to take care of rhythm problems. So that's another very important message, is that if you do have an arrhythmia, this is the right era to have them in, because the progress that has happened since I started in this field, just a few years ago, is amazing. In fact, I was raised in Canada, born here, raised in Canada, and I do like to tell everybody that I have seen what socialized medicine does, and I could tell you in our field, if there's socialized medicine, there will be no more anything. Because the degree to which this field has progressed is 100% from America, 100% because of money, and it has been amazing, amazing, amazing. When I started, we put in defibrillators. So defibrillators are basically like having a 911 team walking around with you. So the problem with most of the dangerous arrhythmias is that as soon as you have that short circuit that is dangerous, you have very little time to bring that rhythm back before it is impossible to bring it back. Because the more that rhythm happens, the less blood flow there is to the heart, the more the heart gets damaged, the harder it is to bring the rhythm back. So it's really a moment where time is money. And particularly in New York, we know what 911 does here. It's a disaster, very slow to get to you. You know, the survival rate will be literally zero almost for these dangerous arrhythmias. So what we do is we try to predict ahead of time who is at risk for this rhythm, and we try to fix it by putting in this little defibrillator. So what the defibrillator does is it essentially watches over you. Tell everybody it's a little bit like a seatbelt. You're not going to use it. Most people will never use it, but then if the rhythm actually happens, the abnormal rhythm happens, it will shock the rhythm back. Now, just to give you an idea of what's happened in this field, when I started, I actually put the first defibrillator in with my team at Penn. When we started, the first defibrillator was you cut the chest, you open up everything, you put a patch about this big on around the heart, you tunnel wires, and you put a machine, and I'm not exaggerating, about this big, it's about a little bit bigger, a little bit less than that in your abdomen. So it was about half this size. It was huge. Okay, that machine would look for the rhythm problem and would shock it. That's it. I presented a paper at the American College showing that they were actually not saving very many lives because people were committing suicide with them because they were so scared of them and because they were shocking them inappropriately because they were brand new. Of course, that was not a paper to say they weren't useful, but to say we need to do a better job at designing them. So move now to a few years later. And how do we put them in? We put numbing here. We make a little nick. We pass a wire by X-ray into the heart. We put a machine about this big under the skin, and you go home the same day or the next day. You can imagine how much that is a difference. Now, not only is that the difference also is now they record wirelessly what's going on. They tell you everything going on. Every day we get a little message from our patients. They can pace the patient out of the rhythm. They can pace the patient in normal rhythm. They can do ring bells and just like all of our cell phones, as many things as you want. All of that in 20 years. That's amazing. That is a huge difference. So why am I saying that? First of all, it's very important that we all recognize we have to support our healthcare the way that we need to support it. That's number one. And number two, it is to say that because this change has happened, there really is no excuse to allowing people not to have this defibrillator if we can find the people that need them, right? They save a lot of lives. They are very expensive. They cost about $20,000 to $30,000. But if you compare that to the use of airbags or use of smoke alarms, the chart for per life saved is about this big for the cost for airbag, and for the defibrillator you barely see the line because they save so many lives. So these are very, very important messages to say that we do have tools that do fix these arrhythmias, and they're going to be taken away from us if we don't pay a little bit of attention. But on the other hand, we also should pay attention to palpitations. There's going to be far less desire to look after things and get things because it's going to be harder to get the money to do it. Always got to keep that in mind. So the same way that these defibrillators have progressed, there's also been an amazing progression in the ability to record. So now I want to talk to you a little bit about that. First of all, anybody have any questions about defibrillators? So I think it's better to talk while we present. Anybody have any questions? Yep. They have to, because as I said, is much, much, much cheaper than almost any other thing per life saved. The way Medicare generally decides is that you have to prove that it is cost effective. Actually, you just have to, in this day and age, that's not even true. In this day and age, you just have to prove that it works. So this works very, very, very well. So they have to pay for it. So yes, they do pay for it. They'll pay for it for specific reasons. So they have cracked down very much on what they'll pay for. And in fact, it causes a little bit of problems, but that's also very appropriate. I mean, there is an appropriate dialogue between throwing it in everybody and putting it when we need it. So these are the discussions that are happening, is to define who is it that should have whatever tools that we're using. So right now, without a doubt, if you have the criteria for it, they pay 100% all of the defibrillators. Mm-hmm. So the defibrillator has two parts. One is a wire. That's the hard part. That's the part you have to get into the heart. And the other is a box. The box has a battery. So the question was, how long do they last? The box has a battery, and they last about 7 to 8 years. A pacemaker lasts about 12 to 15 years. Depending how much you use it, the pacemaker. Sometimes it's only 7 years, depending on how much you use it. Pacemakers are much, much smaller, but you put them in a very similar way. So every 8 to 10 years, you have to change whatever machine you have. That is actually a very, very simple change, but again, it's another good chunk of money.
It's maybe getting a little too technical for the conversation, but how does that battery last 7 to 10 years when, I mean, I'm thinking a normal battery, like a cell phone, dies in a few hours, you know? I mean, why can't we...
I'm glad you're asking that question. It has to do with the ions that they use inside. And in fact, the big limiting step, they have lasted 8 to 10 years for the last 20 years. We have not found a revolutionary battery. Revolutionary batteries would be extraordinarily useful in a lot of cases in medicine. They have the ions that are used in the battery are actually last that long. And they actually there is a whole system to reionize them all the time to get that to happen. So that's a very good question. But interestingly, that's been a big rate limiting step. We're all saying, why doesn't it last longer? Because they haven't changed, which is interesting. Yep. Pacemaker and a defibrillator. So a pacemaker will take care of slow heart rate. So it is much easier to take care of a slow heart rate. All you need to do is get one of those little muscle cells to start, and then the rest will follow. So you don't need much energy to do that. That's very easy. A defibrillator is going to bring back a fast rhythm to normal. So when you have a cardiac arrest, it's a very big misnomer. 99% of cardiac arrest is actually a very fast heart rate. It's not a misnomer because the very fast heart rate causes the heart to no longer contract. That's the arrest. But the rhythm is actually fast. Okay, so that's what a cardiac arrest is. So what the a defibrillator does is it'll take, so interesting, remember I told you when we put them in, we would put a patch on one side of the heart and patch on the other side. What you do is you send electricity through. So I don't know if anybody has had a cardioversion or knows what a cardioversion is. The more common arrhythmia that we haven't yet talked about is atrial fibrillation. Atrial fibrillation is the upper chamber getting out of control. And if you want to bring that rhythm back to normal, you'll see that what we do is we'll put a patch on your chest and a patch on your back, and then we'll put electricity through. So if you think of the 911 movies you've seen where they come in and go, zzz, and they put the paddles on and push, that's basically what you're doing there is you're taking that surface, you're taking the other surface, you're sending a big surge of electricity through, and that will wipe out all of it's sort of like rebooting your computer. Wipe out all the short circuits and let the normal one come back. Okay, so that's what that is. What the defibrillator does internally is the same thing. And what they did that's really smart, that allows us now to do it by the vein, is that patch, they converted it into a coil. And they put the same surface area onto a lead. And so therefore you can put it into a vein. So you have a lead with a coil, and you use those two coils to send the electricity and bring the rhythm back to normal. Very clever. And they use the box that's out there. So now you have different ways to send that electricity through, zap, and bring the rhythm back to normal. So that's what a defibrillator is. Leadless pacemakers. Not yet. So Marianne's asking a very good question, especially that we pioneered it in Mount Sinai. One of the big problems with these devices is that I just described to you, they have a lead that holds this, and then you thread it through the vein into the heart. Well, it turns out those leads, as you can imagine, are the sort of the linchpin of this problem, of this device, because they every day are getting beat up because they're inside the heart. So they're going boop, 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 boop. And they're sitting here where you're going like this and doing things. So that gives a lot of wear and tear to the leads. So leads cause a problem because they'll often fracture. Well, not often, fortunately. They'll rarely, but they do fracture. And then the other big problem is that they sit in the vasculature. So they're in your veins. And I'm sure you're well aware that one of the concerns with valves and with the heart altogether is that there are bugs do go into your blood. Now, we have a good system to get rid of the bugs, but if you have a piece of metal or any kind of device, and I'm sure you've all heard this, if you have any kind of device in your body, those bugs love the device and they'll try to hook onto it. And then they hide in little cracks within the device. So the leads are commonly a source of infection. They don't cause infection, but if there is an infection, they'll adopt it. Oh, let me just finish. So what we invented was a pacemaker that does not have any leads. Now that sounds kind of crazy, and it kind of is. And what it is basically the pacemaker now, instead of being a box like this, has become a thing smaller than my finger, and it has a little screw in it. And we pass it up into the vein, and we just screw it into the heart, and we walk out. So the whole piece is there. And amazingly, that little piece will talk wirelessly outside. So the wireless theme is a very interesting one because it's brand new. In the last 5 years, the degree to which we can record is amazing. Question? perfect segue to my next part. So what I was going to say is, how do we record? Okay, so as what the question was, what are the signs of heart attack? But actually, there's not a heart attack. There's cardiac arrest. So I want to actually make that distinction. It's actually a very important distinction. Both are lay terms, and both get used wrong very frequently. A heart attack is actually when you lose blood to the heart and it damages the muscle of the heart. That's a heart attack. Those are the plumbers. I'm the electrician. The electrician, we do cardiac arrest. So cardiac arrest is when the rhythm gets out of whack. All right, so there's a distinction there. So when people tell you heart attack, cardiac arrest, they often tell you the wrong thing, first of all, but it is important to clarify which one it is, because it's completely different what you need to do for them. So we're talking here about cardiac arrest. So how do we know if your palpitation is going to be the kind that leads to a cardiac arrest or not? So as I said, the first thing that you do is you talk to your doctor. You try to describe it as much as you can. I'm glad to tell you don't worry too much, because the description is not going to make a big difference ultimately. Because what we're going to do is we're going to risk stratify you. What does risk stratify mean? It means we're going to try to put you into a bin, your high risk, your low risk, and what kind of risk. And the way we're going to do that is by looking at the structure of the heart and by looking at the arteries of the heart. Now, there are a bazillion tests you can do for each of those, and that is the specialist decision based on a bunch of other criteria. For example, I'll give you a simple example. One of the things you're going to want to do is look at the arteries. How we look at the arteries depends on your cholesterol, your family history, you have hypertension. So there are many different ways, because all the tests that look for any heart structure problem have a possibility of giving you wrong answers in either direction. And so we want to give the right test for the right person to get the best correct answer. So I'm going to put this out there because it's a little bit tough concept, but it is very important to understand that most tests have a false positive and a false negative. I put the first one first, which is a false positive. So tests can tell you have problems that you don't have. And that is a problem, because that will lead you to getting treatments or other things. So you have to be careful. You don't want to always have tests all the time, because you may go down the wrong road. So it's very important to understand that sometimes it's right not to do a test. All right, so I know that's a bit of a difficult concept. And also, very often, it's important to do the right test. So for example, with artery disease, and I'm sure Marianne talks about this all the time, the tests that you do for women are different than the tests you should do for men, or should be interpreted differently. We recognize that for a young woman, you shouldn't do the same type of testing that you should do for a middle-aged man, or then a man who's already had artery disease, because the probability of getting right answers is different. I know that's a bit difficult, but I think it's very important to put out there. So we would have a cardiologist decide on what testing to do to define well what is going on in the arteries, what is going on in the muscle of the heart, and what's going on in the valve of the heart. Okay? And we're going to decide what of those tests to do based on a few simple things. So from our end, if you came to me with palpitations, what we're going to want to do is very quickly risk stratify to see that there aren't any dangerous things on your EKG. You'd be surprised that a regular EKG can pull out most of the dangerous things for young people. So that's the good news. And a lot of the dangerous things for older people. So it is very important just to start with the EKG. No, you will not have your palpitation while you're doing the EKG, unless you're really a good patient. That would be very unusual. So most people, of course, will not have. In fact, we will then put a monitor on you that you will wear for 24 hours. People always say, but yeah, I won't get my palpitations. No, you will not get your palpitations. Very unlikely. And if you do, again, thank you. But usually you will not. But what we're doing that for is for the same thing, to look at what environment these palpitations are in. Are there things you feel, don't feel? What are your heart rates? What do you do when you exercise, when you sleep? All of these things play into our ability to identify those patients who are at risk of having something dangerous. And then we will almost always have at least an echo or something of that nature that lets us see the muscle and the valves. Because with those three pieces of information, majority of people, we can decide if there's something to worry about or not. Now, if there's something to worry, we're obviously going to do more tests. There are lots of other tests we could do. But those would be generally the main screens, okay? Now, in this day and age, it is changing a little bit because, as I said, we can capture your palpitations. Problem is your palpitations aren't happening all the time. And if you have your first sign of palpitations, our first job is to decide how long can we wait to catch those palpitations again, or should we be being a little bit more proactive, right? So those first 3 screens are really just to say, okay, it's nothing dramatic. We can now capture the palpitation. So how are we going to do that? Well, we're going to do that by what I just said, wireless technology is wonderful. So we have many ways of capturing rhythm problems by special little toys that we have. So we have lots of different monitors. Some are plaques that have little electrodes on them. You put in your pocket and you keep it. So the person that has a palpitation every blue moon, they can take it out, put it on their chest and record it, and then we have it. So that's actually the one we use the least because it doesn't record all that well. And it only records when you have the palpitations. So the first thing we usually will do is give you a monitor that you wear all the time, that you can take off and shower and stuff like that. And it actually communicates to a cell phone, then the cell phone actually sends to us what's going on, so that we can sort of see what's going on. That way, those machines do 2 things. First of all, if you get your palpitations, you push the button and tell us, this is my palpitation. But it's also screening you all the time to see whether or not things are happening that you don't know about. And it will actually capture those and they will send them out. So those are very, very useful. What's happening now are 2 things. One is instead of those little leads that are annoying, there's now patch technology. You just slap on a patch. It's really just happening right now. You slap on a patch, and that actually patch you can go in the shower and everything with, so it's much, much more tolerable. And it has also a little wireless thing that speaks to a cell phone that then tells us what's going on. And then one step further, which is really going to come soon to everybody, believe it or not, is a little thing we stick under your skin. So I would guarantee you in the next 5 years, there will be a very tiny thing you just put under your skin that will wirelessly tell us everything going on. There already is, we actually inject right now a little monitor that's about half the size of half my finger. Put a little nick, inject it underneath, and it wirelessly will tell us what's going on. Why do we do that? Because those last 2-3 years. So when we're screening for potential risk of a certain arrhythmia, that's obviously a very tolerable thing because it's under your skin. It doesn't have the risk of infection, just local. It's very 0 risk to put it in, and it will tell us what's going on night and day. So when would that one be particularly useful? For somebody that has palpitations very rarely, or for people that have risk of arrhythmias that the rhythm isn't dangerous, but it has other consequences. So what is that arrhythmia? The number 1 arrhythmia we have, atrial fibrillation. Before we go into atrial fibrillation, anybody have any questions about the monitoring that I just described or how we screen? Mm-hmm. So the arteries is more complicated because it can either be a stress test, a stress echo, a stress thallium, a CT angiogram, an perfusion MRI, I could go on and on. So that is where we need our plumbers to do the risk stratification on their end and decide which is the best test to screen out for coronary disease. Or the number 1, final answer is an angiogram, but that has risk. So that's why we will always work with a general cardiologist, almost always, to determine what is the best test. I mean, if it's a young, healthy person, we know that the easiest stress, we just do a stress test with a thallium and then we get an answer. But if it's a little more complicated, we'll have a cardiologist do that part for us. So that is all important for artery disease. So that's a completely, you're talking plumbing again. I don't know. No, don't listen to that anymore. Yeah. So angiogram is again, that's plumbing, but the risk of any time that you are invading into the artery, there's a small risk of causing a stroke. And there is a risk of causing bleeding around the entrance thing. Now, I have to tell you, with all the modern technology, that's become almost non-existent, which is great. There's actually always also, you're going in to take pictures into the arteries, so there's actually a risk of causing a heart attack by stripping it when you're in there. But the good news that's obviously very bad news. The good news is usually that only happens if you were already at risk of having that, and then they usually fix it like they would have anyway. So the risks have gone way, way down for that. But it's still invasive, right? So it's not, otherwise everybody should have that, right? But it does have risk. Now we have CT angiograms, which are very good. And there's CT scans that look at that without going and invading, but the downside to that is this radiation. So you don't want to give people radiation who you can do something easier for, right? So that's where this becomes a little more complex. Each of those tests have, some pros and cons. Okay, so let's talk how we doing on time.
We still have 25.
Beautiful. Okay. So now we're going on to our next big topic. And this is a big topic, and everybody knows about it because there's so many ads on TV. We're going to talk about atrial fibrillation. Now, why are there so many ads on TV? We can all guess, because it's very common, and therefore there's a lot of money. That's why you get ads. So it is a very, very common problem, atrial fibrillation. And it is increasing dramatically. Why? Because it is definitely higher incidence as you get older. So that is a big, big arrhythmia and a very, very big problem. Now, why is it a big problem is a little bit surprising, because I just said it's called atrial fibrillation, and I told you the atrial rhythms, the upper chamber ones, are generally not dangerous. And indeed, this rhythm is not rhythm-wise dangerous. So what happens in atrial fibrillation? Atrial fibrillation, the upper chambers start contracting, start beating irregularly. So instead of your normal rate going one, both upper chambers together, both upper chambers together, lower chambers, upper chambers, lower, this gets chaotic and it starts running around like 300 beats per minute. So the consequence of that is two consequences. One is you start now sending the conduction system, remember, the conduction system determines the heart rate, you start sending 300 beats per minute towards it. And so it has to block that. So fortunately, your conduction system is well designed to slow the heart rate. Now, it doesn't do it perfectly, so you will very often have slightly higher rate in atrial fibrillation. And interestingly, that can have quite a large gamut. So some people in atrial fibrillation naturally will have heart rates of 80. Majority will have around 110, 120, and then some will have 180. That heart rate is not dangerous, okay? It's going to give you palpitations, but as I said, it's going down the regular conduction system, so it's not dangerous. The upper chamber, we don't need it, so that's not dangerous. So atrial fibrillation, rhythm-wise, is not dangerous. The problem is that those upper chambers are no longer doing a very good job of contracting. So that doesn't cause us problems in terms of the blood flow generally, we don't care. But what it does do is it allows the blood not to circulate very well up there, and then occasionally what will happen is a little clot will form. And in the heart system, whenever there's a clot, if it goes flying, it will preferentially go to the brain. Because, of course, we're designed to have the blood flow to the brain be protected, because it's important to have blood flow to the brain. The bad news is if a clot is in that blood flow, it's going to go to the brain. And so that's a stroke. So the problem with atrial fibrillation is that it causes stroke. The bad news for women is women are more likely to get a stroke if they have AFib than the men are, for whatever reason, which is interesting that we don't actually know. It surely has to do with our hormonal balance and how it affects the stickiness of cells. But we do know that women have a higher risk. So when we have atrial fibrillation, we actually define who is at risk by a bunch of factors. Do they have congestive heart failure? Do they have hypertension? How old are they? So not only, double bad news, not only as you get older are you higher risk of having AFib, you're also higher risk of having a stroke if you have AFib, so double whammy. And then the women, if you have diabetes, you're higher risk of having a stroke with the AFib. And obviously, if you've had a stroke before, you're at higher risk of having a stroke. So we look at those factors, and people who have some of those factors, we have to take care of making sure they don't have a stroke. Okay? The way we do that is we have to thin their blood. So here's another very interesting change, in many ways change, in a field of arrhythmias. And that is that, first of all, I just told you we can now identify the people with atrial fibrillation better. So remember, I raised this because I was talking about putting a little chip under you. Okay, now very many people never feel their atrial fibrillation, and many times they're actually relatively short, or happens during your sleep for a few hours. So we know there are people out there with those higher risk scores who have hypertension, diabetes, and we know that a significant number of them are going to get atrial fibrillation, because not only, again, is that risk, those risks make you more likely to have AFib, but then you're more likely to have a stroke if you have AFib. So double whammy again. So if we can put that little chip underneath and pick those people out, we will very likely be able to diminish stroke. So we're actually doing a study right now of that, multi-center study. But that is going to be the future, is going to be trying to pick out the people before the stroke happens. Obviously, that would be the way to go. Particularly that we now have treatments for the blood, with blood thinners if the atrial fibrillation is found. Now, again, life in medicine is always a little tough, just to make it fun for us. It's a double-edged sword. So we are going to try to stop you from having a clot. But the reason you're having a clot is because when your cells see disruption, they make a clot. And why do they make a clot? Because usually that means you're bleeding somewhere. That's a protective mechanism. So unfortunately, we're going to undo a protective mechanism. So of course, there's a downside to that. So our job is to try to figure out who has AFib. But once they have AFib, who is better off to have a blood thinner or not? Because if we're going to cause some bleeding, then there's already some negative from the blood thinner. Now, this is a very, very important thing because I have a lot of patients that come to me from their cardiologists who said, why are you not on a blood thinner? And they don't understand that there's, you can't always be on a blood thinner and have a better success. There are a lot of people who the risk is very low of the AFib causing a stroke who are better off not on a blood thinner, even though they have the atrial fibrillation. So again, this is a time where you want to have a real expert be able to identify the pros and the cons and decide about the blood thinners. The good news is the blood thinners have gotten substantially better in the last 2 years. And that's what's causing all the ads. So up till a few years ago, there was only warfarin as a major blood thinner for atrial fibrillation. And as everybody keeps telling us, that's rat poison. And yes, it is rat poison. It's rat poison because it causes you to bleed. So what we did to kill rats was to give a lot of Coumadin to make them the blood very, very thin, and then they would bleed. So again, it goes to say that when you're thinning the blood, you have to thin it right. The problem with Coumadin, which is the old standard, was that it doesn't thin the same for everybody, so it was a little bit hard to manage. So a lot of energy was put in to develop drugs that will affect the blood thinning in a very stable way. And these are all the new anticoagulants that have come out in the last 2-3 years. And so since they're brand new, there's a lot of fighting over who's going to be the best one. And there's a lot of concern about whether they're causing problems or not. So there's a little bit of anxiety over them because they're new. But they're so much better in terms of the ease of administration and in terms of staying stable that they're very rapidly becoming very popular. Now, the great news, and I think another really important message, is that we are in a new era. We're in an era of big data. So as much as that's annoying from what we all hear with NASA, blah, blah, and it's very concerning. For medicine, this is an amazing moment for us because we can actually now get data. If we can categorize it well and do good studies and crunch the data well, then we may be able to get really good answers and start defining very well who needs what. Much, much, much better than we have in the past. So this is a big frontier for us that is very difficult because doctors were not trained to do that. And as you know, the government's doing it for other reasons, and it's very important that there's intelligent interaction between the doctors and people that can gather data. In fact, Mount Sinai has developed an entire project on that. I don't know if you guys all know this, but it's a very big and very brilliant idea where they got a big software developer who was nicely retired, as you can imagine, and decided to come and help us out with this because it's so exciting. So this is a big initiative at Sinai, which is very, very interesting. And so I would say in the next 5-10 years, we were going to have a lot better way of identifying who needs what treatments, and we're going to have much better tools to do it with. So I think that's probably the most important final message. There's a lot of hope, and we need a lot of help, and be very patient with us for the next 5 years, but we will have answers, I am sure. So with that, any other questions about anything?
Just a very general question. If you are experiencing palpitations, would you first go to a cardiologist or go to a electrophysiologist?
I think really generally you should go to a cardiologist. Any good cardiologist would do those screens, but I would just say it's pretty simple. If they can't tell you what your palpitations are, you should go the next step. That doesn't mean that they should treat your palpitations, but they should be able to tell you what they are. Okay, we have the tools to do that.
Any reason why palpitations can be stronger in the morning rather than the night?
Very good question. The question was, is there any reason why the palpitations might be stronger in the morning than in the night? Our system our hormonal system is completely different in the morning and the night. most heart attacks happen in the morning. So that could be why. Your whole, our system is actually ridiculously complex if you think about it, because we have to get our blood up here and we stand up and gravity goes that way. So we have a very complex system to try to keep blood up here. And when there is a disconnect of any sort where the blood pressure changes, we might feel that as a palpitation. So often when you're waking up, you go from, having light flat. So the palpitations may be much more, very common that people will feel their palpitations at night. Now that is because you're not doing anything else, so it's very easy to find them. Plus your heart rate is slower, so if you're having skip beats, the difference between the skip and the normal is much greater than when you're running around. So that's why often people feel them at night more.
Blood pressure, how does that fit
Into palpitation. So the question is, does blood pressure fit in this? Well, blood pressure fits in that for the reason I just said, that a disconnect, if your blood pressure is changing, you might feel that as a palpitation. So it is quite common, I would say probably 30% of the time that people have palpitations here or there, they actually have no arrhythmia. So be careful. When I say they should be able to tell you what the palpitations are, they may be you have normal rhythm. That is an acceptable answer. But then they should have recorded while you're having your palpitations. It may be that we record and we see normal rhythm. Then it's not an arrhythmia. Then it's a perception thing. And that's probably related to changes in blood pressure. So I just want to clarify that because that's important. They should be able to tell you what's happening during your palpitations, but you may not have an arrhythmia during your palpitations. That's an acceptable answer.
Suppose you don't have palpitations, but you find that sometimes your blood pressure is very low, or sometimes it's, not high.
That's plumbing.
What's the relationship between blood pressure and palpitations?
So the only thing is, if your blood pressure, let's say you stand up and you drop your blood pressure by standing, the way you're going to get the blood pressure back up is you're going to increase your blood pressure, you're going to clamp down on your arteries, and you're going to increase your heart rate. That may be felt as a palpitation. It's normal rhythm, but it may feel like a palpitation. Does that make sense?
Is there a relationship between palpitations and exercise?
Yes, definitely. So that's a good question. Is there a relation between palpitations and exercise? So, yeah, is there a relationship between palpitations and exercise? So the answer is yes, and there's also a relationship between arrhythmias and exercise. They're not necessarily the same question, right? But I'm going to say both. Exercise completely changes your physiology. So sometimes that will elicit the arrhythmia. And also sometimes that will make the blood pressure change. So at the end of exercise, for example, your blood pressure, your vessels are very dilated. If you stop all of a sudden, then you may feel a sudden surge or drop in blood pressure, and in response you're going to feel a palpitation, just normal rhythm. But also the adrenaline and all the changes that happen in exercise may produce an arrhythmia. So that's very important. So to us, if the palpitation happens while you're actually exercising, we get worried about that. If it happens when you're just finishing exercising, we get a little less worried about that. So those physiology is very complex. Yes? What's the importance of stress tests that they advise to take as you get older? I'm not sure who's advising that, but that's probably not a bad one. But stress tests are very interesting in many ways because they show your blood pressure with exercise, they show what your heart rate's doing, and they screen you for artery disease. So you have 3 things that you can see through a stress test. Most of that is to screen for artery disease.
Things like palpitations or arrhythmia, are they at all hereditary? Because I know something like heart disease tends to be.
Good question.
So
Are palpitations or arrhythmias inherited, or inherited possibly? So the answer is absolutely yes for a minority, but actually yes for the most dangerous ones. So yes, if you have, and I think, thank you for saying that because I should have said it, if you have a family history of sudden death, obviously this is not good, and that is something you should, if you have palpitations, have screened. But actually, you probably should have that screened by a doc. Every doctor should know that because, as I said, sometimes we can just see it on the EKG, even without arrhythmias, it should be looked at. So if you have a family history of sudden death meaning somebody dies suddenly with no known reason, and if that is when they're younger. Anything under 60, that's something that should be, somebody should be screening you specifically to answer a few questions. So that's important. The other thing I should say based on that is if you have palpitations and you have big dizziness with it, and certainly if you have fainting, all of those are worrisome signs. They may be absolutely nothing. In fact, the majority will also still be nothing. So I don't want to scare everybody, but on the other hand, it raises, you shouldn't just not take care of it. You should go get a screen in that situation.
I just wanted to ask you about any relationship to menopause.
Oh, good question. Good question. So many things we could talk about. So menopause is everybody's favorite time. And one of the lovely things that it does is it gives palpitations. Absolutely. As the hormones changes, unfortunately or fortunately, and one reason we get them more in pregnancy is that all the cells and those gating that I told you about, they are actually modulated by progesterone and estrogens. So definitely you get more palpitations during menopause, and the large majority are nothing. But again, small minority. Of course, as I said, as we get older, AFib is more common. So you just want to make sure it's not atrial fibrillation. So just get it recorded. Yep. What happens to the body when you're under stress? So so stress is a very broad word, surprisingly, and as you all know, because there's mental stress, there's exercise stress, and there's sudden stress, and there's all different kinds of stress. But the long and the short of it is, generally speaking, stress equals more adrenaline. More adrenaline triggers these gates these channels, and it gates abnormal channels more than it gates normal. So that's why it can provoke quite readily arrhythmias. Do we still have time?
Can you talk a little bit more about the relationship between anxiety and mitral valve prolapse?
Okay. Anxiety, mitral valve prolapse, and palpitations. That's a whole other topic. So we'll do one after that. Anxiety definitely produces adrenaline. It produces adrenaline when you're not exercising, so you don't have the other physiological changes, and that's disruptive to the system, and so therefore is often associated with palpitations. Lot of women who have arrhythmias are told they're anxious. That's because a lot of women who are anxious have no arrhythmias. So it is actually a very difficult differential to make. So anxiety will definitely make you have normal rhythm feel like palpitations. So that's the problem. But it will also, anxiety, because you can be anxious and have an arrhythmia. And you can also have an arrhythmia and surprise, that makes you anxious. So you do need to differentiate them out. Since women are more likely, young women are actually more likely to have some of the looping tachycardias, the arrhythmias that are not dangerous. They're often just told they're having anxiety when in fact it's a perfectly treatable, easy to fix rhythm. So again, if you're having palpitations during anxiety, just get a recording. We'll know what it is, right? So the key is to get a recording and see what it is with one of our little tools. Yep. So the question is taking a baby aspirin routinely. So that again is really, okay, so from the rhythm point of view, and I'm going to say that very categorically because the data about aspirin, most of it is related to coronary disease. And I believe now we do not, I actually don't know the answer for the coronary disease because it changes. But I can tell you for arrhythmias, including atrial fibrillation and that question of clotting, the data is less and less favorable to using aspirin. So we're moving away from aspirin because it unfortunately does not help the kind of clots that occur with arrhythmias. So from the arrhythmia point of view, there's not much role for aspirin. From the vascular point of view, there's lots of roles of aspirin. I just don't know who should take it when they don't have any vasculature. But if you have coronary disease, should women take it? Yeah. Marianne is going to answer that question because it's very important.
Different in men and women. So we know that in men at age 50. Okay.
Walk on up.
Okay, sorry, because I'm the general cardiologist, so I can answer the questions about the plumbing that Dr. Langan. So we know that men at age 50 who take a low-dose aspirin have a reduced risk of heart attack compared to men who don't. So men, it's easy at age 50. Women, it was more complex. In the largest study of women, ages 45 to 75, women who took a low-dose aspirin had a reduced risk of stroke. But it wasn't until age 65 that they showed a reduction in heart attack risk. So what we say, at age 65, talk to your doctor, and you have to balance the risk and benefit. If you have a bleeding ulcer history or a blood thinning problem, then you might not take aspirin. And it depends on how many risk factors you have also. So if I see a 50-year-old woman, but she has diabetes and she smokes and she has hypertension, then I would recommend taking an aspirin at even a younger age. So that's the individualized therapy. But in general, the guidelines are at age 65 to talk to your doctor about heart attack prevention. Okay. Go ahead.
Heart attack, she did a good job. Yes?
Yeah, there are drugs that would be helpful in terms of anxiety.
Question is, are any drugs that would be helpful in terms of anxiety? Are you asking in terms of diminishing palpitations and anxiety? Yes. Yeah. So generally speaking, yes, we have very good adrenaline blockers. And of course, you don't want to block your adrenaline everywhere because you need your adrenaline. So what has happened is the production of what we call cardioselective beta blockers. So adrenaline has alpha and beta pieces. The part that works on the heart is beta, but it also works on the lungs. So there are drugs that are specifically beta 2 receptor agonists, which means they block the antagonists, excuse me. They block the effect on the heart. So those are very good because they will give you less palpitations. Now, with anxiety, you may actually want a more complex blocker because you might want to block your anxiety in your brain too, which is adrenaline driven. So sometimes you may take a more broad one, which would be Inderal, which is a slightly more broad beta blocker. Atenolol, metoprolol, low pressor, those are all words. Corguard. They're also, because that's cardiac also, right? So those are all used. So that's a good thing. So if you have hypertension, we'll use that and get rid of your palpitations and your hypertension at the same time. I'm getting signs of we're done. So thank you. Thank you. Oh, that's new.